Good afternoon, everyone. Good afternoon. My name is Endashaw Omer, and I'm a gastroenterologist at I got the invitation to speak about trouble swallowing or dysphagia, and it's an honor. It's my pleasure to share my experience in with you guys. Just feel free to stop me. Feel free to stop me at any time. If you have any questions, I'm happy to answer. Okay, we'll get started. So, as you all know, that there are different types of myositis, dermatomyositis, polymyositis, necrotizing autoimmune myositis, and inclusion body myositis. All of them could affect muscles of swallowing, the pharyngeal or throat muscles, which we'll see in the next few minutes. So normal swallowing is a complex process. It involves a lot of muscles and nerve fibers to get food from the tip of our tongue into the stomach. So the whole process involves different functions, different parts of muscles. We will see there are different. We'll see each one of components in the next few slides, and we'll point out which part is affected by myositis. There is an oral phase. We start from as soon as the food gets into the mouth until it reaches here in the esophagus. This is the airway. This is the tongue. The whole process is to make sure food gets from the tip of the tongue into the esophagus and down into the stomach without getting into this air pipe or trachea. So the tongue moves food around the mouth and chewing it, cut into small pieces, moistening it, and get into the esophagus. This is the oral phase of the esophagus, from here to here. The pharyngeal phase, which starts as soon as food gets here, it's a complex process where the food will make sure that it wouldn't go down into the trachea. The epiglottis closes, completely close the airways, and this soft palate or the larynx tightly closed so that food wouldn't go into the nose. So preventing food going into both upwards and into the airways. To make this involves a number of muscles that could be affected by myositis. This is a part of the swallowing process that's affected in myositis, because these are voluntary muscles that coordinate with the nervous system, ensuring if there is any weakness, as we'll see in the next couple of slides, food might go down into the trachea and swallowing might be difficult. Let's see if I can get the slide running on a video, normal swallowing. So as you can see, the food is being chewed. This is the tongue. This is the epiglottis that protect the airways. This is the soft palate, protects food from going. As you can see, goes up, blocking. This will go down, blocking the airways, and food passes into the esophagus. This is when someone has dysphagia or trouble swallowing, as you can see, food will come down sorry, being chewed. Normally they should go up in closed, without being closed, but this is more leaking. So patient will cough to clear that piece of, in worst case scenario, it might go all the way down into the trachea, causing aspiration pneumonia and all that. So this coordinated process to make sure food doesn't get into the airways and goes where it should, into the esophagus. The second part, as we said, oropharyngeal, getting food from the tip of the tongue into the esophagus. The second part is getting food down from the esophagus into the stomach. This part
Could you move to the side here?
Sure.
Stand in front of the slide.
This part of the swallowing process is not affected by myositis. The muscles involved in the esophageal phase are called smooth muscles. Myositis affects only skeletal muscles. So this is not affected, but I just put it for the sake of completion. This is how it works. Like this, it's not voluntary at all. We have no control whatsoever. As soon as food gets the top of the esophagus, it's smoothly peristaltic way, push it down into the stomach. So coming to, so what happens when this normal process is affected? We call it dysphagia or difficulty swallowing. So it occurs about a third of patients who has myositis, and especially in inclusion body myositis, could be about 2/3 of them could have some degree of dysphagia. Dysphagia is disabling and potentially life-threatening, can lead to pneumonia, as we saw in the earlier video, that food could go into the airways. And it can also lead to inadequate nutrition, dehydration, as eating becomes progressively difficult and people try to avoid eating because it creates discomfort and cough. There are two broad dysphagia which I alluded earlier, the oropharyngeal from the mouth to the upper throat, here to, and the esophageal dysphagia, that's the second part. Second part will not be affected by, it's not affected by myositis. Let's discuss a little bit more on oropharyngeal dysphagia. It's difficulty moving food from the, or any liquid from the throat, in difficulty initiating swallowing. Food could accumulate in the mouth, spills out the corners or from the back of the mouth, and it might even go into the nose, causing gurgling and some uncomfortable feelings. It might also pass to the vocal cords into the trachea, causing respiratory distress. It could be even fatal. The esophageal dysphagia symptoms is completely, patient will swallow without coughing, without any trouble. But as soon as food gets down, patient will have feeling of something sticking in the chest. As I alluded earlier, this won't be a manifestation or presentation of myositis. There are several causes of oropharyngeal dysphagia. Stroke is the commonest cause, but myositis also could be. Overall, if you see the overall picture of oropharyngeal dysphagia, myositis accounts only the minority. But there are other several causes that we see on day-to-day practice. The symptoms: difficulty in chewing, difficulty in initiating swallowing, There is always sensation of lump in the throat, trying to clear the throat, drooling, pain, bad breath, change in voice, hiccups, weight loss, heartburn, all could be symptoms of dysphagia. One should keep an eye for warning signs when you might consider somebody might be suffering from all the myositis might have affected swallowing muscles. May take a long time to begin swallowing. Might need to swallow 3 to 4 times for a single bite, because food will sit there and feel they need the feeling to swallow. Coughing and frequent throat clearing and wet gargle. Slow. It might take a long time to eat. This is kind of adaptive mechanism of people to prevent aspiration. It's not without complications. Several complications could occur, like malnutrition, weight loss, dehydration, choking, pneumonia, aspiration. Even aspiration without causing pneumonia could cause respiratory distress and could be even fatal. And depression, people will be depressed and distressed that they are not able to eat. Eating will become a big normally eating is, we don't even think about it. So it's a conscious effort. People are cognizant of their day-to-day eating, that could cause depression. Diagnosis is established by several things. One, history is extremely important. As I said earlier, we ask all those symptoms and watch patients, we watch all those symptoms. And we can do simple bedside swallowing assessment. We ask patients to drink a few ounces of water and watch for delayed swallowing, coughing, weight or hoarse voice quality. And we may wait them for a couple of minutes and see if there is a cough response there. We can complement that bedside simple test by other diagnostic testing with modified barium swallow or video fluoroscopy. This cleans the diagnosis. This is a very important test that helps us know whether any oropharyngeal dysphagia. This requires the patient to drink a contrast solution containing barium, and they mix it. They made it in different consistencies. Then real-time X-ray picture or fluoroscopy is used. It can be examined in slow motion and see physician or speech pathologist examine the entire swallowing process and see what happens when swallowing takes place. Endoscopy can be used to see if there is any mass or any block in addition to muscle weakness. I have a video for that. We'll see if I can see. Here, the radiologist will ask you to swallow different consistencies, thick, thin, and see. As you can see, it's mostly passes. This is the black thing in the contrast, the barium. As you can see, it's coming down. This is the airway. It's not going there, and it's quick. It doesn't take even a second. It just immediately passes from the, this is the tongue, goes down. This will be examined when the speech pathologist looks at it. They slow it down and assess if there is any pulling of the contrast in the throat, or it's going down. Let's say abnormal So this, you will see this one. Gonna swallow. As you can see, it's going down here. It's pulling, it's taking a lot of time for the contrast to go down. So that tells there might be some problem in getting this contrast into the esophagus where it should go. They try to elicit cough response, if that helps in getting, so they ask the patient to cough and it was able to go in. And they tried with different consistencies to pick the right amount of what the patient can do without any trouble. Let's go over what do we do when someone has trouble swallowing, or pharyngeal, or the other name for this is called transfer dysphagia, which means transferring the food bolus from the tip of the tongue into the esophagus. So your doctor or speech pathologist, they are called speech pathologists, speech language pathologists. They may exercises. There are certain exercises that help coordinate or strengthen the muscles and nerves. And there are swallowing techniques. They are fairly effective in teach patients body positions to help swallow without having discomfort or risk of aspiration. There are some exercises or new swallowing techniques that could help strengthen weak muscles. There are some interventions that could help reduce swallowing problems, tilting the head down to place food back so that you can help some part of weak muscle. If weakness is on one side, to place the food on the stronger side. If there is a problem with tongue pushing the food down, putting the food back in the tongue might help. Small sips, small bites, and it's always recommended to sit upright for about 30 minutes after eating. Other meal interventions to give 100% attention to the eating process, avoid distractions. And there are speech language pathologists, SLP. They have different maneuvers that can help you to counteract specific problem you are encountering during the swallowing. Based on the video fluoroscopy, based on their exam, based on your history, you will have specific tailored regimen that helps improve the swallowing process.
What did you call that regimen?
Swallowing maneuvers. They are speech language pathologists. They are trained technicians. They have different techniques to help you counteract or improve weak muscles. It's always good to eat slowly, smaller bites, and sometimes they can specifically recommend special utensils. And to adjust temperature of the food, the taste and texture. Generally, it's recommended to avoid dry foods, moisten with gravy, sauce or broth, and you have to wait until swallow is complete before taking another bite. And it's always to check mouth carefully out, and always never rush, be attentive. That's the most important thing we always tell patients is just be cognizant of your eating. Just be attentive every bite, make sure that everything, that bite process has been completely successful without causing cough or aspiration. Other things could be thick liquids, coercive tight foods. It's better to serve in food in cold or hot. It's believed to have better outcomes in terms of reducing aspiration.
Could I ask a question about the cold and hot? Why is that so? Not cold or hot? Not warm, not warm, okay.
Yeah.
Why is that?
The cold or hot extremes stimulate the swallowing reflex. So as soon as you put, the problem is swallowing reflex might not kick in, so that stimulates swallowing reflex to get the food out of the mouth.
And it stimulates the cheek and the mouth muscles as well for the oral phase.
Yes.
So that it can be, your mouth is better able to do the chewing and do the moving around that it needs to get it ready to swallow. So it wakes it up for that, and then it wakes up the reflex when it's actually trying to set it down. So, and that's where the sour comes in as well. That's also a stimulating, awakening up kind of input in your mouth. If you think about the difference between sucking on a lemon versus sucking on an orange, and the difference in how it like makes your mouth feel and kind of, oh, hi, hello, I'm awake now. And your muscles kind of respond in that way as well.
I think we'll have time for questions after this finished, and that way I can give you a microphone so that everybody can hear the question.
Well, thank you. So, sometimes bad things could happen like choking. If a small amount of anything liquid wouldn't cause choking, you may cough it up, but subsequently you may develop pneumonitis, which is just inflammation of the lungs without pneumonia because of whatever went into your lung. Or one might develop pneumonia down the road in a couple of days or so. But once in a while, sometimes, if people might develop choking, complete blockage of the airways. If that happens, you have to stop feeding immediately, call for assistance. If there is someone who knows Heimlich maneuver could be used to get that piece of bite out. Especially recommend to sit forward or lean on one side. Do not drink or anything, liquid or anything, with the hope that it might take it out, so you're making things worse. And maybe suctioning could be done, because anything, you cannot swallow anything, it will accumulate and it might even go into the airways. Always follow recommendation of speech language pathologists. They are experts in this. They know a lot about this, and they will guide you through, and they will have specific regimen for each patient. So, if all efforts made to help patients able to eat by their own natural means fails. We see some patients going in and out of the hospital because of aspiration pneumonia. Speech pathologist efforts fail. Then the other alternative is, we call it internal access or feeding tube. It can be accomplished by several means. If there is expectation that swallowing would recover in like 4 weeks or 6 weeks, we can place a feeding tube through the nose into the stomach, or into the first part of the small intestine at the duodenum, or into the jejunum, the NG or ND or NJ tube. We don't recommend this to last longer than 6 weeks because it might cause pressure necrosis or inflammation in the noses, or it might cause sinusitis. So we use that if we anticipate that patients will get better in a month or two. If the expectation is that the patients might not get long-term feeding is expected, we opt for prolonged feeding through the stomach. We call it gastrostomy tube. If we place endoscopically, it's called PEG, or jejunostomy tube into the small intestine. This one is more durable. Both of them could be durable, but this one ensures that there won't be any aspiration. But the G-tube, because we put the food in the stomach, there is more risk of aspiration. This is how it looks like. Just the abdominal wall, put the tube, and hook it again in the wall, and this will heal, and it's a permanent for months, years, but we cannot remove it shorter than 8 weeks. If one commits to a PEG tube or J tube, at least it should last for 8 weeks or 2 months. If you remove it, there is a risk of serious complication, peritonitis, or any infection. So if once placed, at least 2 months. But we normally don't place it for 2 months, because if we anticipate that someone needs only for 2 months, we use the NG tube or NG tube. This is how it looks like. So the tube comes out, there are ports to feeding, to hook. This is the jejunostomy tube in the small intestine, the second part of small intestine. Feeding will go directly in small intestine and can be used for years. This is a button PEG, so this less stigmatizing, especially for kids. They can swim, they can do anything with it. The problem with this is it's not as durable as that. It needs to be changed every 6 months, and it's a bit more expensive. Okay, thank you. If you have any questions, please feel free.
Take microphone to those who have questions.
Hi, I'm not a patient, I'm a spouse. Those are not mutually exclusive, of course. But anyway, my husband has talked to his family physician about a feeding tube and decided against it. She suggested to him that even with a feeding tube, you can choke to death on your saliva, and that it often occurs. It can occur if it's that bad. So, would you comment on that?
I don't think one can, unless there is blockage in the esophagus, unless blockage. So this is the esophagus. We make saliva, especially when we eat or when we anticipate to eat. Anticipatory salivary secretion or in the process of salivary secretion. We constantly make saliva, but not so much. Even if the amount of saliva we make, if there is no any blockage, it will trickle down and slowly goes down into the esophagus, down into the stomach.
So you don't swallow, it trickles?
Yeah, it trickles subconsciously. We sleep at night, we don't swallow while we are sleeping. We make saliva while we are sleeping, but not as much. But it goes down. So it's very, very unlikely, but to cause, he will not to cause some sort of aspiration in the life, but that wouldn't be, that would not be, should not be the reason not to place a feeding tube. Even after feeding tube, depending on the degree, the severity of trouble swallowing, we recommend what we call pleasure eating. we ask patients just a tiny bit of whatever they like. Speech pathologists will pick, some people will aspirate for liquid, others with solid. So your husband could get evaluation by this, and they will pick what type of food is the least risky for aspiration. Is it liquid, solid, semi? And he can have a little bit of that once in a while for pleasure, not for nutritional purpose, not to meet the nutritional requirement.
Any question?
I just want to comment, how about the patients who are diagnosed with sleep apnea together with DM? Or any kind of, sorry, I'm going to repeat. So how about the patients who are diagnosed with sleep apnea and they're diagnosed with myositis? I mean, that could cause that problem too. Like saliva doesn't go trickle down, it just stays there in the mouth and they can't breathe.
Sleep apnea, what the relation?
Well, if the patient are diagnosed with sleep apnea or tonsillitis too, like they have enlarged tonsils, that you don't have enough space for them to either swallow or breathe. So if the person is secreting so much saliva and it just sits there, like I had this problem with me was, even at night I would wake up like I was choking. And the other problem was because of the inflammations, like I would eat and not go to bed for about an hour or so, and then when I go to sleep, I could not lay flat. Like I had food that will come up, and it felt like it was sitting in my mouth, and with the saliva, so I was always on a thickened like a diet. Water was hard to drink. Even saliva, I had a hard time swallowing my own saliva. So I can relate to that. Your husband's like, just sit in the back and just stay there till like I have to like make myself swallow. And I think one of my doctors was like, maybe you also have sleep apnea. And I was like, I wasn't ever diagnosed with sleep apnea, but that question came up.
I think what he was referring, not the sleep apnea per se, but one of the causes of sleep apnea is tonsils or arytenoid. There is big tissue in the oropharynx, in the posterior, that could impair airflow. When you are sleeping, the tongue will drop, relax, and cause airway blockage. But the amount of saliva, what we are talking about is the reflux. It's mainly reflux. When you sleep, when you lay down, especially if you eat a few minutes or an hour before you go to bed, the pressure in the stomach will build up. It's easy to calm contents of your stomach, and people choke, wake up in the middle of the night. It's mainly because of reflux. The saliva will eventually go down. It might cause minimum, but I don't think that's the big part of the problem. And we recommend not to eat at least 3 to 4 hours before going to bed to minimize and raise the head of the bed to at least 45 degrees, or put 4 to 6 inches of block. Probably not a pillow, but the whole bed should be up, that to create gravity to prevent stomach contents going up.
Back over here,
Hi, I was recently referred to the University of Minnesota to get a procedure, and I don't know a lot about it because I haven't had the appointment yet, but maybe you do. It's to deal with the sphincter and to cut.
hold the microphone closer.
To heal the sphincter, or to work with the sphincter, to do cuts in it, to allow food to go through. Have you heard of that?
Sphincter, the upper sphincter.
It's like a pharyngeal.
Scratching the top.
Cutting, yeah, it cut. Yes. Yeah. Do you have Zenker's diverticulum? Did they say that? You have diverticulum?
I don't know.
You know,
I have problems with this. Shuts over your airway.
epiglottis? Yeah. When there is the cricopharyngeal is one of the muscles that helps coordinate the food passing. This is a so this is the cricopharyngeal muscle. This relaxes normally as soon as the food comes down. It relaxes, opens. We call it upper esophageal sphincter, that the food could go down. In some patients, during, after long years of swallowing, this muscle could get tense. It doesn't relax, it doesn't open. So people having other problems high up, cutting this sphincter to relax it might facilitate passage of the food go down. So you don't want to have normally, that's what we call swallowing reflex. I alluded earlier. As soon as the food comes here, the reflex will kick in. This reflex, one of the things that reflex does is relax this muscle. Yeah, if it's not standard of practice, but some areas would try it if it helps. It's commonly done if one has what we call Zenker's diverticulum. It's a type of pocket that forms right here, and to get rid of that pocket, they do cricopharyngeal.
There was a woman in one of our sessions this morning who spoke about that. Were others of you in the session when the woman told about having that cut?
I've had it done, yes. I've had it done.
Are you the person? Okay, I thought you were.
Just a minute, and we'll go there. We have one question back from that.
I think you answered part of the question. I believe I have esophageal dysphagia, so it feels like it's sticking in the top of my throat. So is that just general muscle weakness around the esophagus? Not starting the motion for swallowing, or is it some nerve deterioration that the muscle is not getting a signal to swallow?
So the problem, the esophageal part of dysphagia start from where right the upper esophageal sphincter, where the cricopharyngeal sit down, where the esophagus meets the stomach. This problem could happen for two main reasons. One, simple mechanical blockage. Something blocks it. That something could be one, tumor, two, scarring. People who have a lot of reflux heartburn disease that heals and leaves behind scar tissue, we call esophageal stricture. Or others could be rings, Schatzki's rings. And the other esophagitis, inflammation of the esophagus because of it. These are the mechanical things that could block So those are mechanical things that could block the esophagus from here up to where it meets the stomach. So we have to find out what's causing it. But unfortunately, you cannot localize it where it is. You may feel, even if you have trouble swallowing here, you may feel it here. Even if the blockage is down here, patients tell us, oh, food is getting stuck to me right here in my throat. But in fact, the blockage could be right here.
Physically, I know it's right here. I can feel it. If I can't swallow, I can easily cough it.
Yeah,
it's in my mouth. So the question is,
yes,
simply,
okay.
if it's right there, so peristalsis is just not starting. Is that the problem? To get the food to go down my esophagus. Is that?
Yeah, I'm coming to that on the next. So one is the mechanical part where there is blockage. It could be higher blockage. The other two is the motor part. The motor means the pushing, the movement. So the movement part could be what we call dysmotility, esophageal dysmotility. So it might not, peristalsis might not start at all, or it could be not coordinated. But normally, as I showed you earlier on the picture, the process is when it contracts here, relax down. Contract like you push toothpaste from the tube. That could be the problem. But if so, you don't have any choking spells or anything like that. You just feel it. So it's very unlikely that it's esophageal. It's not the transfer dysphagia. The food has made its way into the upper part of the esophagus, past the airways. So it's a problem with pen. We can do a testing. Esophageal manometry could be done, which a catheter will be placed through the nose in the stomach, and you'll be asked to take about 10 cc of warm, salty water, and we'll measure the pressure and see how is the peristalsis or starting, or how the pressure, what the problem, all those could be figured out.
In relation to myositis to metamyositis would be causing the lack of peristalsis.
Yeah, in the upper part, yes, the beginning, yeah.
Hi, my name is Emily Warhol, and I have a problem at nighttime. When I lay down, I have like mucus accumulate in my throat, and all I do is try to swallow, but I can't swallow it, so I take a tissue and I spit it on my tissue, and then it clears. But I've had stretching of my throat, I've had speech therapy, and I still have a hard time swallowing. Now, what type of exercises do you recommend? They gave me to do exercises for my throat, and they're kind of silly. I can demonstrate if you like. They told me to go put the tongue in the back and go put the tongue between my teeth and go as long as you can, and then to go like chuck and luck and do like those kind of exercises with CK. So do you recommend any other exercises, and what do you recommend for the swallowing at nighttime? I can't swallow it, I have to spit it out of the tissue because it's kind of thick.
Yeah, that's a very good question. Because your swallowing is mainly conscious. You are doing it consciously. That's why you are during the daytime. You are not having those spells. At night, it's subconscious. The saliva is going, triggers reflex, and the muscles will contract, relax, and get the saliva down. I think you are doing the right thing. Speech pathologists are doing the several training sessions. It might take a long time to strengthen and make the coordination come back. And I think you need, have you ever had pneumonia or anything? Aspiration?
No.
Okay. So,
What other exercises do you recommend for the throat?
I don't think stretching wouldn't help. Stretching, yeah, because it's not about a mechanical thing I just talked about. It's a motor thing. Stretching is not going to help at all, unless you have narrowing for a different reason. Like I was done myositis if you have because of reflux or other things. If you have narrowing of the esophagus, yes, stretching might help. But for this, there are several, depending on when they do the video, I cannot recommend blanket this type of exercise. It depends on which side of your airway is pulling. Like when they do the, have you ever had video fluoroscopy? The fluoroscopy, the bearing. So they would do which side is pulling, what type of food.
They tell me to put my head inside to swallow.
Yeah.
Down or,
Yes, down 30 degree, down.
you know, and I've tried all that. And sometimes I can swallow normal, but sometimes I can't. But what are the exercises that you recommend besides the two that are there any other exercises?
I cannot, I think those are the most important to strengthen the throat muscles.
Yeah, well, what do you do to strengthen the muscles in the throat? What exercise do you recommend?
The one you mentioned,
When I mentioned,
yeah,
just do it.
yeah.
Thank you.
Just a quick comment and see what you think. But if someone is prone to having difficulty swallowing and could choke, would it not be a good idea for someone in their household to learn how to do the Heimlich maneuver? You don't have to be medical, you just need to know how to do it. And I think local hospitals or American Red Cross or your doctor could help connect with that.
Yeah, absolutely. Yeah, everyone should learn how to do it. It's easy to do. Just between the. Yeah, it's easy to do as soon as when you recognize just all the person. If it's an adult, for kids it's different. It happens from young adults. You hold between the umbilical and the navel in the chest. One big thrusting motion. If that doesn't help, do it another time.
I've been having some swallowing issues sporadically. Like I know, like if I get bread or pork items, like they get caught and I can't breathe. And I live alone, and it's happened twice. Both of them happened to me home, and they saved me. But it gets caught in my automatic responses to drink something to get it down. But the internet says don't drink, you have to cough. But
That's what
but my instincts are automatically get something to drink and get it down.
No, absolutely no.
Is there any home remedies that to suction it out that are on the market? Like if you're home alone and this happens, like is there any home suctioning kits out there or something?
No.
Because now I'm scared, what's going to happen when I'm home alone. But like with a tablespoon of olive oil get the food down? Something just, because it gets stuck, but he's done the Heimlich on me and got it out.
You can do your own Heimlich.
Do the Heimlich on yourself.
Yeah.
Use a chair or a table and get it in that same position and then push yourself against it so that that's the same thrusting motion. That and making the food moister, so
Yeah.
pork with gravy now.
I notice when I wrap my foods, like a hamburger or something in lettuce, I eat it fine, but if I eat something with a bun, a sandwich with a bread, it's always getting stuck.
So skip the bread, it sounds like. Change your food.
And also, you didn't mention the TPN. I was on TPN 20 years ago, about 4 months, and I survived. So there's TPN out there in addition to those tubes.
I would recommend TPN.
What is TPN?
Total parenteral nutrition. It's nutrition through the veins. That is recommended for someone who has gut failure. Like if you are not able to nourish someone through the gut, yeah. Someone who has short gut syndrome, but unable to tolerate feeding through the stomach or the small intestine, because TPN has a lot of side effects. It can cause sepsis, it can liver failure, several complications could happen if you use it for long. So I omitted it on purpose because for the type of patients who have this type of trouble swallowing, TPN is not an option.
Our time is complete. We've had a great speaker, and I hope you've gotten your questions answered. If not, I think we'll probably come up and talk. Please turn in your survey so that we know what to give you here.
Myositis Association, helping patients become peers now for the past 25 years. So if you have been diagnosed, here's an organization to unite us. 8,000 members they can boast. For that real strange word that no one's heard, it's myositis. There's an annual patient conference which is just second to none, where you'll learn a lot and network, and you'll also have some fun. And their website is updated with a lot of current news, with lots of info and resources, and much more that you can use, like info TMA compiles, and like lists of clinical trials, and lists of research too. You can review, cause it's all there for you. So hooray for the group TMA. It's the Myositis Association, helping patients become peers now for the past 25 years. So if you have been diagnosed, here's an organization to unite us. A quarter century they can boast. They've been the group that's got the scoop on myositis.